Thank you all for getting up early and being here. My name is Jim Scheulen. I'm the Administrator for Emergency Medicine at Johns Hopkins. And with me today is Dr. Greg Volturo, the Chair of the Department of Emergency Medicine at the University of Massachusetts. Kain Robbins, the Administrator from Penn State. And playing the role of Steve Maxwell today is Tommy Borman from Roundtable Analytics. Steve had an unfortunate accident that, as Dr. Volturo says, proves that exercise is not necessarily good for you. So the content this morning, what we're going to be talking about is part of an annual survey that the Academy of Administrators, working with the Association of Academic Chairs, work on every year. We've been doing it now for about 11 years. And there are really two major parts to the survey. One part has to do with operations of the ED, hospital-based information, and we'll talk about that at 10 o'clock today in this same room. This part of the survey has to do with faculty life, research, the research part of the mission, and salary, which typically captures some attention. So we're going to talk about this in a number of ways. Each of us will be talking for about 5 or 10 minutes, and then we'll have time for questions at the end, we hope. And if not, there's always a hallway outside. So let me open up just by briefly describing to you, according to the data, who we are. We being academic emergency medicine faculty. First of all, we have a very, very good sample size of physicians. In fact, it's the largest group of academic emergency medicine physicians that there is in terms of salary comparison. Many times universities will use another benchmark, but we find that the number of physicians in that survey are in the hundreds versus the thousands. And so we feel that our data is fairly reliable. It's interesting that our faculty has been out of residency on average for about 11 years, and 9 of those years have been where they currently are. And so even though sometimes it feels like people are moving around a lot, it actually looks like people seem to stay in one place, at least for some significant period of time. It's interesting that over half of our faculty have been out of residency and in practice for less than 10 years, and almost 30% have been out of residency and in practice for less than 5 years. So it's a relatively young practice of emergency medicine, and that explains the reason, I think, that we have such a high proportion of our faculty as assistant professors. Now, what you'll see is, what I would assume we'll see is that as we age into more seniority, you'll start to see growth in both the associate and professor ranks. As far as race and gender, we have not seen too much change over the years, although there has been some change in the gender distribution, and we'll talk about that in a second. But frankly, we are still largely white and largely male in terms of who the faculty are in emergency medicine around the country. Now, as far as gender is concerned, there are two ways to look at this. When you see the data come in on an annual basis, what you begin to see is that the incoming faculty have sort of a 60-40 split between men and women. 4 or 5 years ago, that was more like 70-30, and 8 or 10 years ago, it was 80-20. And that sort of plays out still, so you can see that the more senior ranks and the more senior faculty tend to be even more heavily male. Last year, the inbound team seemed to be at a 60-40 split. The year before that, we thought we were really making progress when there was 50% male and 50% female who entered the faculty in year 2016. We also know that our female faculty are among the youngest faculty. In fact, 63% of our female faculty have been in practice for less than 10 years. So that's a little bit of a snapshot of the demographics of the faculty. There's more information, but those are the high points. So let's talk a little bit about money. We know that there are a number of factors that impact how much money you make, what the faculty salaries are. And all of these things that are here in bold are significantly related to salary. So whether or not you have an administrative job, what that job is, and how much time that job takes matters. How long you've been out of school, how your academic rank, where you work, whether you're male or female, and how many clinical hours, all have something to do with your salary. It's unclear, and even when we look at it using sort of traditional statistical methods, you can tell, to some extent, the interplay between these, but it's a very complex question, what makes up physician salaries. You would think that there would be, for example, a fairly direct relationship between how much you worked clinically and how much you got paid. But when you look at all faculty, it's not entirely clear that that's the case, because as academic faculty, you have a number of other sources of income, a number of other sources of funding, a number of other responsibilities besides clinical care for which you're reimbursed, for which you're paid. And so if you look at this information, you see that there's no real relationship between clinical hours and salary until you look at the subset of faculty that define themselves as primary clinical faculty. Then there's a relationship between hours and salary. So that kind of assessment, that kind of analysis is sort of where we're going, just to be sure we understand what's behind the numbers. The numbers are this. So for the first year ever, average salaries have touched the $300,000 mark. Now that includes chairs and chiefs. If you take them out, it's just a touch below at $296,000. What's important to know is that the salaries are increasing at a pretty substantial rate, about 3.5% from last year to this. And the total salary is rising slightly faster than the base salary. You'll hear in just a little while that there are all kinds of different compensation plans that come up to building a total salary. And so what we're finding is for the second year running now, total salaries went up at a rate slightly higher than base salaries, which would suggest that places are beginning to rely more on some kind of incentive, some kind of bonus, some kind of non-guaranteed salary to get you to your total salary. And you can see that in 2013, 86% of total salary was base salary, and now that number is only 83%. As far as first-year faculty is concerned, first-year faculty can expect to make in the ballpark of $256,000, also an increase from last year, but a very relatively small increase over last year. There was a substantial increase in the first-year salaries 2 years ago, and that's sort of moderated over the last year. So, as I said, base salary current represents about 83% of the total. Base salaries have gone up about 11.5% since 2013, but here's the key message. Look at the rate of increase of total salaries for faculty over the last several years. It's about 3.5% to 4% per year. So if your institution, like ours, sometimes gets stuck in the 2% cost of living increase cycle, then your salaries are going to fall behind instantly. And so this is, I think, an important number for the administrators or those of you who represent salaries at your institution to sort of keep in mind. It's interesting that it used to be that the western region must have been the most beautiful part in the country because they used to pay significantly less than the rest of the country, despite the fact that people say it's pretty expensive to live out there. But you'll see that 3 of the regions made significant adjustments to their salaries so that essentially salaries across the country are there's very little difference, if any meaningful difference at all, between regions at this point. However, rank makes a huge difference, as you can see. And what you've seen is that at each rank, salaries have increased over the years, but there's a substantial difference between ranks. And it's also interesting to see how long people are typically out of residency in each rank. And so you can see that the typical person who's an assistant professor has been out of residency for 8 years, and the typical person who is an associate professor has been out for 15 years. And so given the fact that, as I told you on the first slide, our faculty has been out about 11 years total, we feel like we're right on the cusp between sort of the assistant and the associate professor level. This is just an oddity, right? There are faculty can define themselves, or we can define faculty by various roles that they hold. And there are some faculty who are primary clinical faculty. That's their job. They have very little else to do except work clinically. And so what we find with the clinical faculty is that at every rank, this is no surprise, they work more hours than everybody else, more clinical hours. But the interesting thing is they don't make more money. And so it would suggest that then that in the academic setting, there is real value placed on things other than clinical work. And so this is one of those curious findings, though, that we'll be looking at a bit further. This is the first time we looked at it this way, and it was an odd finding, but something we'll look into a little bit more. And then, of course, there's there's this one. Yep. Whether or not you look at it on the surface or whether you statistically adjust for all of the other things that impact salary, there still appears to be some difference in gender and salary based on gender. So once again, it's good to be a guy. Now, I'll tell you that we're getting a fair amount of questioning about that because many places say, well, we have a formula, and so I don't understand how that can happen. Okay, then let's try to understand it. So there's a number of groups, including folks from the AWEM group, from our group. We're still trying to dig around with this gender issue and see if there's something that is absolutely identifiable that can be fixed to adjust for this issue. Now, that issue does not at all exist, interestingly enough, when you talk about NPs and PAs. We have salary information on about 750 PAs and NPs. And what's interesting about that group is there is no difference in their salaries. PAs and NPs make the same amount of money. PAs and NPs do the same thing. PAs and NPs work in the same parts of the emergency department as each other. This is a group that is 70% female, 30% male, and salaries are identical. Now you can say, well, that's because they work straightforward clinical schedule. They basically have a salary. That salary is set by either the School of Medicine or the hospital, and they work according to, just straightforward hourly rates. Fine, but that's the way it is. The other thing that's interesting about the PA salaries is that there's a pretty narrow range. So not much difference between being a PA one place or another in terms of salary. Now, salary is one thing. How you get to the salary is another thing. And this is where you add a whole nother layer of complexity. There are 4 different ways that we build compensation plans in emergency medicine, and Dr. Volturo is going to talk about them. But they can be as simple as you work, I pay you a salary, period. That's it. You get a salary. Then there's a 2-component system, a 3-component system, and some places have a 4-component system where you have a base salary, some incentive salary on top of that, a stipend for some administrative work that you might do, and then additional payment for extra hours that you might work over and above your commitment. And so literally everything from I'm going to pay you a straight salary, don't talk to me about anything else, to this complex 4-component system, and Dr. Volturo is going to take over from here.
Thank you, Jim. Before we start, I just have to recognize the slides we're about to look at were put together by Chris King, and I'm filling in for Chris. Lost it. I'm filling in for Chris, who, if you were at the plenary session yesterday, will know passed away about a month or so ago at the early age of 58. So. Okay, compensation plans. These are the secrets that you want to know when you're going to negotiate with your chair, right? Where can you find the money? You could see that the total salary, about $300,000, and you usually start off with a base in that $240 to $250 range. And then there's several components that you could add into, and the compensation plans vary from place to place. And, on average, it's about $18,000, $19,000 that goes into doing extra hours that you all work for picking up shifts, stipends for doing particular jobs in the department, about $27,000. Bonus dollars, you see, are taking a bigger and bigger proportion and representing salary. And then don't forget, when you start to look at, when we're talking to the CFO, it's not necessarily about total salary, it's total compensation. And they include in here another piece which is above and beyond the total salary. It's about $65,000, $66,000 for your benefits. Okay, health insurance alone is about $27,000, $28,000 for most of the plans that we have. So lots of different components in there. And as Jim pointed out, there are basically 4 different types of compensation plans in EM. And the thing also to keep in mind is that depending on the type of compensation plan you have, your salary will change with it, right? So single plan has the lowest salary. where with 2-component, 3-component, and the highest salary, about $322, based on the 4-component plan. And that makes sense now if you're thinking that the 3-component plan includes your extra hours and a bonus, but you're now getting a stipend for doing other work. The 4-component plan is more valuable to you. You can see the percentage of docs in each area, with the majority of our docs really being in the 3-component plan. The 4-component plan, again, only has folks who generally get a stipend for doing some kind of other work. Where you don't want to be is down here in that single-component plan with no ability for bonus, no ability to get paid if you're doing extra shifts. Okay, so the single-component plan, as you can see, 100% of your salary is base. Only 7% of physicians are in that plan. When you get to the 2-component plan, the biggest one ends up being where you're dealing with base and bonus. And in that plan, you're looking at roughly about 88% of your salary being based on your base salary, and with a mean bonus of somewhere around 12% of salary. When you get to a 3-component plan, again, this is where the majority of physicians have their compensation. It's base, extra hours, and bonus. And you see here the bonus goes down a little bit, and the base now in this plan represents roughly about 84%. Oops, let's go back. Wrong button. 84% or so of your compensation. But you notice that base is still hanging in that 240, 250 range. 4-component plan, again, these tend to be, again, more senior physicians, some administrative jobs, and now your base is representing about 77% of your total compensation, and the compensation is the highest in this group. Now, does your base clinical hours, remember your salary is determined by not only your dollars, but also the hours you work. So does your clinical hours change with your academic rank? And the answer to that is yes. You could see that as a professor, you're working less. So if you're coming in straight out of residency, you're going to expect to work more hours than somebody who's been around for 23 years as a professor. Has this changed at all over the years? And the answer to that is no. Okay, that's pretty consistent in academic medicine. Do years of service matter? And the answer to that is yes. The more years of service, the less clinical commitment you're going to have. Makes kind of sense in that, again, you've been around for a while, you're doing other things, you're probably getting a stipend, doing some other roles within the department also. And this, again, has not changed over the years. How about location? Well, this is where it's all about location. If you're working in the community, you're going to be working more hours. So even with an academic program has community sites. If you're in the community, you're going to work more hours than you will be if you're just primarily in the academic site. Many places that have community sites attached to them have some combination of hours between sites, and you get a blending between the community and academic hours. So, where do most of your colleagues fit in terms of clinical hours? What can you generally expect? Well, you could see that somewhere between 800 and 1,400 hours, 50% of the emergency physicians are working. Okay, somewhere in that range. And that's going to vary by age. It's going to vary by years of service and academic rank. So there's no getting 300 hours of or 1 day a week really for very many people at all. Okay, so here's where the real money is. So you really want to know what everyone makes, right? Now, I'm going to tell you, as I told Jim this morning, the chair's a lion, okay? I looked at that and said, geez, that looks a little low. So I took a look at the AAMC, and the AAMC median for 2017 was 599, with the 75th percentile being 707. So I suspect what we're looking at here, not necessarily underreporting, is that many of us chairs have been chairs for a long time, getting 2% increases when everything else has been going up. And we're all at or near or over retirement age. And so tend to get paid lower. So certainly when I saw those numbers, I'm going in asking for a raise when I get back. So, okay, and I think that's, oh, and then just in terms of hours, if you have administrative duties, you're going to be working less clinical hours. Okay, I think that's understandable for most. Salaries tend to be higher with administrative duties. And then if you look at the distribution, 70-30, kind of fits with what we've seen in terms of distribution, gender distribution, a few years back. Okay, and so if we're looking at folks who are doing administrative duties, they're generally older, been in the department longer. So this is maybe consistent with the finding that you keep hearing from chairs, we treat everyone equal. Because you're certainly seeing that progression in the administrative duties. And I think faculty effort. You want the... okay.
So I'm going to be, is that good? So I'm going to be looking at faculty effort, production, billing, those kind of components of the faculty life. Go this way. So we're going to start with faculty effort. You can see this is a standard, effort distribution, which hasn't changed much over the years. About 70% of the time is spent doing clinical efforts. We spend about 6% on research, about 13% on education, and 11% on administration. The clinical time has increased a little bit over the last couple years, with those other three buckets actually decreasing kind of all slightly over the last 2 years. So looking specifically at some of the breakdowns, the research effort, that 6%, you can see the largest organizations to the left there. Those 5 organizations allocate about 20% of their time to research. So those are highly productive organizations for the research components, and they're the consistent ones year after year. Those haven't changed much either. When you look at it in total, it is decreasing. Like I said, it went from about 6.9% to about 5.9%, so about a percent decrease. But about, I would say about 20% of our organizations are spending 10% or more on research. So it's not that we're not doing research, it's just that it seems to be decreasing a little bit. And about 60% of all the organizations spend about 5% of their effort on research. So it seems like it's across the board, 60% of the organizations are doing it. Somewhat of a sizable, or at least some reasonable efforts on research. And the mean stays at 8%. For education, like I said, that's decreased a little bit, but we spend about 13% of the effort. About half the organizations are 15% of effort or more, and I think that's kind of a base standard as organizations do try to look at that 15%. And again, these organizations are the largest users of administrative time. You can see University of Texas, Houston's at about almost 50% of their time is allocated to education. Louisville has a sizable component as well. So some of these organizations are really investing in their education components. The administrative time is about 11% of the organizations, and you can see the largest users of administration or the allocators of education. And you notice some of the pointer here, right? Oregon Health and University of Michigan were also on the list for research. So those organizations are heavily investing in administration and research efforts. So looking at productivity, so that was effort. Looking at productivity, as a mean, the departments use about a little less than 30,000 hours of physician coverage to cover their department. Production of RVUs is pretty consistent over the years. About 6.7 to 7% is about how many RVUs are produced per hour. And patients per hour around that 2.5 patients per hour number. And that's kind of a standard, regular number that we see year after year. But then we broke it down, wanted to look at that a little bit more and broke it down by the size of the departments. And you can see once you hit about 40,000 visits, that's where you get into that 2.5 patients per hour. Before that, the 40,000, it doesn't mean those individuals are less productive. It's just economies of scale overnight. So those periods where you're going to have a provider, it's hard to get those same numbers up. And so that's why you see that differential. But once you get 40,000, it's pretty consistent all the way up to the largest organizations. Did I do something wrong? Okay, sorry, that was weird. It's just the same information again, but what I wanted to do is layer on the support, the additive components, the extenders, the APPs, the residents, and how does that look when you add those components into there. And so this is the non-physician provider, so residents and APPs in there all together. And you can see, again, the 40,000 to the larger organizations have a very similar kind of statistic where it's about 1.3 to 1.5 patients per hour for those individuals. Again, the smaller, less than 40,000 is a little bit less, but again, that has to do with usage, and you'll see that in a second. So it's not necessarily that those individuals are more productive, it's just there's less use of those individuals in those smaller facilities. So when you combine the two together, that's when you kind of see what do we look like, so how do you know what your benchmark is for your visit. So when you add all the components up, it comes to about 9.9 to 1 hour of coverage per visit is what you kind of need in aggregate for everything. So that's kind of a benchmark you can use for your trying to staff your department to figure out what you need. The daily coverage, again, we have the same breakdowns of the different size of the departments, but you can see about, again, starting with that 40,000 because that seems to be the trigger for when things kind of change. About 35% of the coverage is by physicians, with 65% with those APPs or residents. And again, in the smaller facilities, it's more physician coverage because you have to have those providers and stuff. And just mathematically, it just works out that way that you're going to need physicians and less of the extenders. The interesting part, though, on this is when you go from 40,000 to 100, it's pretty consistent that about 40-some% is going to be residents, the low 20% of APPs. But once you get in above 100,000, looks like that resident component of additional residents is ending, and those volumes are being met with more advanced practice providers in those large organizations. So some billing charge information. This is just some historical information, collections per work RVU and work RVU per hour and all that kind of, and work RVU per patient. Those statistics have been pretty consistent where it's about for work RVU is about 6.7 to 7 per hour. The work RVU per patient is consistent in the 2.8 to 2.9 level. But what's interesting is the collections per RVUs and the collections per visits over the last couple of years have greatly increased. And I think that's, some of it might be better insurance and negotiations and some of that, but I certainly think our billing offices and more focus onto those areas, getting in our charts quicker, getting in our information quicker, being more diligent in our documentation. I think all those things are being recognized and noticed in those figures. So we're basically getting paid more for the same amount of work. So it's good. It's a good thing, right? And we want to make as much money as we can and be diligent about that. And it looks like we're putting some efforts towards that. Professional billing fees. This is just to give you some benchmarks of kind of where you should fall. About 80 to 85% of your charges should come from your E&M. 13 to 15% should be coming from your procedural billing, and most organizations are around 3 to 5% for their observation billings. And that's a benchmark. Are you in line with that? Are your procedures coming in around 14, 15%? That's something you can go back and kind of take a look at. E&M codes. So that's another component of the billing. We've looked at this, and so you can see this is a 6-year spread of our E&M codes. And what we've noticed is the 1, 2, 4 critical care have all kind of stayed the same, but we've seen a change from our level 3s to our level 5s. So the question is, are we seeing sicker patients? Are we Are we, is that what's happening in our department, that we're seeing these higher level billings? Or is it better documentation, better focus on that kind of thing? So the next couple slides are trying to figure out a couple of those components. I'm not sure we figured it out or answered it yet, but we'll take a look at some of it. So one piece we looked at was the comparison of ESI. So our ESIs, are they moving in the same direction? Now we know ESI is not necessarily a direct correlator and a perfect science for billing levels, but we wanted to just see if both of those were moving in the same direction, it might give us a cue to acuity. But you can see in this graph, the years where the ESIs went up, our billing levels went down for those high level charges, and the years that went down, our billing levels went up. So I don't know that there's a correlation to ESI, certainly. And so I don't know that we can pin this on acuity yet. So I took another stab at looking at ESI in a comparison. And this is a scatter graph of the ESI levels, 1s and 2s, and then those high level 5 and critical care billings. And you can see that it's pretty much a big blob of nothingness. So it doesn't look like organizationally, as each organization does their ESIs and their billing levels, it doesn't look like that correlates. So I don't know that ESI is ever going to get us a true measure to determine whether acuity is changing our department's level of billing. So looking at a couple other things impacting your professional revenue. Being a level 1 trauma center, is that going to impact your revenue? And it looks like it does, and it makes some sense. The organizations that are level 1 traumas do have a slightly higher level 5 billing, and you can see it kind of comes from that 3. It's similar to that ESI change. That would make some sense. You're going to be seeing some sicker patients at the level 1 trauma center, and so I think there is somewhat of a correlation if you're at a level 1 trauma center that you're going to produce a little bit higher level 5 billing. Another thing I wanted to look at was scribes. Does having a scribe help your billing levels? And so what we did was we looked at the organizations that have scribes, which are in red, and the ones that do not. And there's no direct correlation because it seems like it's kind of the opposite. Now, obviously, this is just one component of it, but I would say just based on this, the organizations using scribes aren't producing more level 5 billings than those that aren't. Obviously, there's a lot of other benefits to having scribes, but the financial impact on this analysis, I would say, doesn't show that. What we don't have are organizations that didn't have scribes and then now do have scribes, and was there a change in their revenue? We just don't have enough organizations that have made that switch, so we can't analyze it yet, but that's something we can look at going forward as organizations that moved to it, did they see a change? But this is just strictly the ones that do and don't. So, what we wanted to look at is what are the strongest correlators. So we looked at a bunch of different metrics. What is really the strongest correlator to more professional billing? Is it the number of procedures you bill? Is it your level 5s, your critical cares, or a combination of those 5s and critical cares? And what we found was that it is the organizations that are focused on their level 5s and their critical care billing are producing the highest level of billings, and there is a correlation of that. So that's really where the focus and revenue production can come from, is focusing on those 2 areas. And so does procedure capture significantly affect revenue? I think we come out of these a lot of times. How do you capture procedures? How do you get all your procedures that you're doing and capture that revenue? And there isn't a strong correlation until you get to about 40% of your billing, which is not a normal component of, there's not a lot of organizations that are hitting that, but that's the only time where you really see the revenue. So the 10%, less than 10%, 10 to 20, 20 to 30% of your billings are coming from procedures. There's not really a large impact just because it really is a small factor in your overall billing. This is just for informational purpose, the change in payer mix, and you can see certainly in January 2014, we've had some changes in our healthcare policy, which did decrease our self-pay, and you can see our Medicaid population has grown significantly. Our Medicare population has grown significantly from those changes. And then the last piece is I think we need to go back and do a shout out to our professional billing groups and whoever's doing that in your departments. you can see they're doing a lot of work and a lot of good work, producing some very strong numbers. Billing lag days have gone down. Expectations of net collection rates have increased greatly, so the amount of money we think we're supposed to bring in and how good are we at bringing that in. Days in the AR have decreased. Our denial rates have decreased. So what's happening in those billing offices for everyone is really making an impact, and because you saw it with the revenue production per visit. So I think we all need to go back and say good job, guys, because they're doing a great job in reducing these numbers. And then the last thing we looked at was the lag time and whether that really impacted the net collection. And so these are some more outliers, because net collection rate of 50% is not the norm. Those are pretty some organizations that are few and far between. But when you look at the organizations that collect 70 to 80% of what they think they're going to collect, all the way down to the ones that are collecting greater than 95%, you can see that the lag time on these organizations is less. So it does look like the quicker you get your charts done, we can process it and process that bill all the way through. We have a better chance of collecting the revenue, and so that would make sense. So when us as administrators go back and say, please get your charts done, please get your charts done, it does impact our revenue. So it is important that you give us at least a little bit of a listen to on that one. And I think that's mine. Tom?
We're going to be right up against the time limit, I think, at the end, so we'll try to stay in the room until we take it down. If you have questions, and otherwise, we'll stick around for time.
Where's this guy? All right, well, I'm going to stand in for Steve Maxwell. We worked on some of this stuff together. It was pretty interesting. The work on the research portion of the benchmark survey, it represents a lot of work that the research subcommittee of the benchmark committee put together, and Steve's a big lead of that. And I think one of the key ideas that is trying to be understood here is how does the investment in research by a department eventually translate to research success by, as measured by publication, peer-reviewed publications, research grants, et cetera. And I think that's more of the long-term goal, and I think the changes that have been put in place for these questions are going to help us over time see that. And it's a difficult question, but I think everybody would be very interested to understand what's the formula for creating a research enterprise if that becomes a priority for a department. And so yes, this is the research component. So of the institutions that reported for the benchmark survey this last year, we're really looking at 55 academic centers that reported active grants. Of those, 44 reported some type of NIH grant. And so that's kind of the group of universities and institutions that are reporting the grant funding. And we'll see some representation from others also who are academic centers that reported no grant activity. And so when we start to look at how they break down a little bit, what's the profile for these different groups of institutions? So at the top line, we have the NIH-funded institutions and what's their collections per faculty over the course of the year. Interestingly enough, across the different groups, the median collections per work RVU was essentially identical. And how do they compare to the 27 academic centers that reported no grant activity the last year? And that actually doesn't mean necessarily that they didn't have grants, but they reported not having grants. And then the non-NIH funded group with 11 sites, kind of similar. And so you get to see a little bit of a profile. So we're starting to understand who these institutions are. What was the success rate like in fiscal year 2017? And this is this conversion rate, which represents the number of grants successfully funded from grant proposals that your faculty have submitted in your department. That number fluctuates over time, and so last year was a little bit on the low side with about 41% conversion rate. I guess last year was quite high, almost half of your grant proposals were funded, and that's cyclical. But what we do see here is an increase in activity in terms of the number of submitted grants across the responding sites at least. So where are those grants coming from? So we see a lot of representation by NIH of different types. So the NIH R-type grants and the other type grants each had more than $20 million in total spend last year in fiscal year 2017, and you can look at the average spend per grant. Interestingly enough, their largest pure number of grants were industry-sponsored grants, but the spend for each of those was quite a bit smaller, so the total dollar amount over the course of the year was a little bit less than some of the NIH classifications. But then you've got other federal grants and other grants overall that are all in over $10 million range. So you start to see where they're coming from. And I think a lot across the NIH grants, with the exception of the K&T grants, that $130,000 to $160,000 annual spend was kind of typical. So this is where the benchmark survey is going. This is the focus of the research subcommittee. Starting to understand that formula for creating or generating a research group, a productive research group as a department, if that becomes a priority. What does that investment look like? What does that formula look like? And so what's the relationship, we hope we see one, between grant funding and publication rate of the faculty? And then finally, how does the financial performance, how is that impacted or related to grant activity? And in some of these cases, these are ongoing questions that I think that this year's survey starts to tackle, but it's going to be some multi-year responses will be needed to really address these. So not surprisingly, the institutions that had active grants, NIH or any type of active grant, had more median publications per department, and we're going to actually look a little bit at publications on a per faculty basis to start to understand maybe these are the big departments and they're more productive because they have so many more faculty. But what we wanted to do is start to look at some of these relationships between something that might represent a research investment by the department. And in this case, the x-axis here is the total number of FTEs that are that contribute to the research effort. So the sum of all the percentages across your faculty, what's the total number of research FTEs represented, and what was the peer-reviewed publications by the faculty. And we see, in this case, this is one of the, it's noisy, of course, but this is one of the relationships that popped out as somewhat important here, is that not surprisingly, as we have more research time for our faculty, they've been more productive. So in other words, they seem to be taking advantage of the time they have to publish by doing so. And this question is much more challenging. I think it's going to take several years of data to get at. But how do investments in junior faculty eventually translate into research productivity at the entire department level? And the first thing we can do to start to look at that is how variable is the time that we protect, the research time or the clinical hours reduction that we provide to general faculty or that are provided to general faculty. How does that vary across departments? And it varies quite a bit. And so the stack on the left says that of the institutions that reported this, there were 5 that had 0 to 10% roughly of protected time for junior faculty. And that ranged all the way up to a reported value of in the 60 percentile, in the 60% range. And so that could be quite a bit of variation in how this is actually managed by the EDs, but it also could represent maybe some rewording needed, because that's a lot of variation, I would think. The question is, and this is a tougher question. If we invest in the junior faculty, eventually how does the productivity department-wide for research increase or decrease? So what's the relationship between how much we protect our junior faculty with a research appointment and the peer-reviewed publications per 100 faculty? And it's just all over the place. So we don't see a relationship yet. It would be nice to say if we protect the junior faculty, we can expect this. And I think it's going to take several years of data because of course, there's going to be a lag between protecting the junior faculty's time, them building up a research portfolio and beginning to publish and get grants over time. So we see the same sort of lack of an apparent relationship between protected junior research appointment and total grants per 100 faculty. So no apparent relationship there, but something to watch over time. Now, if we compare the total amount of research effort in terms of FTEs, and we say, what's the ratio of research FTE to clinical FTE? So this is being higher on the x-axis here, translates to more emphasis on research as a department compared to clinical. Not surprisingly, we see at least a weak correlation between that and the number of peer-reviewed publications per 100 faculty. So that's what we expect as the overall effort is more geared toward research as opposed to clinical. Again, the faculty are being productive and producing both successful grants and also successful peer-reviewed publications. So the previous graph was peer-reviewed. This is now the grants. So we see, again, there's a lot of noise and a lot of other things apparently going on here, but we do see that there's some relationship between those. So what are we learning? I would say not what did we learn, but what are we learning? So I think we need to understand how to better characterize the different components of faculty time and understand not just clinical and non-clinical, but also what's the emphasis on research versus teaching versus the other components. And so some new questions or new data elements could help us get at this problem. And I think it's important, but it's also, again, this lag effect of protecting junior time might lead to, or an increase in protecting junior time eventually will lead to a more robust research portfolio across the department. But that's going to take several years of data to be able to track that kind of activity. So I think that's it.
That's
Hopefully.
it. Yep. Thank you very much,
Yep.
Tommy. So, by the way, just Tommy found out just a little over 12 hours ago that he was doing that presentation. So,
Terrific.
be happy to answer some questions. I think also, if you have questions, the request is that you go to the microphone so that we can catch the recording. Did we confuse everybody completely, or is it just that clear? In the back, please. There's a microphone coming to you.
I have a question about the research. Do you actually drill down to the individual faculty in terms of the publications they do, and instead of aggregate numbers?
The questions aggregate at the department level. How many peer-reviewed publications is the department producing? So there's no data on the amount of time this particular professor's time is protected, and then how many publications they produce that particular year. So it's department level.
How about rank and also publications? Like if you're at a professor rank or associate professor rank, how many publications do you do per year?
Not at the moment. That's interesting.
Yeah. So the way we collect the data with it, that's a very interesting question. What we have to be careful of, you can imagine, and if you're here for the 10 o'clock hour, you'll see this survey asks hundreds of questions, and it takes a great deal of effort to complete the survey. So there's always a balance between getting great information by being very specific and overwhelming people, right? And so the way we actually collect the salary data is, in fact, by individual faculty member. So it would be possible to ask for the number of publications by faculty member, and then we'd have it by rank as well. It's just always a question of the balance between getting data and overwhelming people with the request. But that's a very good question that might be very important to gather.
The other issue, though, it's not just the number of publications.
Yeah.
It's where it's published, right? Because it's really the impact that you're looking to find out. What is the impact? So, publication in family medicine isn't going to weigh as much as a publication in the New England Journal of Medicine. So that's a very difficult one to get to. We do. We've been working on a project that actually can be used for academic promotion, where we actually look at all the publications that you would have in PubMed and Scopus, and then actually weight them based on where they are. And it's very interesting to look at it from that way, but it's a very labor-intensive way of trying to document what our faculty's productivity is when we're coming up for academic promotion. It's one of the things that we have to present for academic promotion. They're less interested in volumes of publications than they are for the impact that we've had.
Yeah, that's what I'm getting at, actually. I think there's a little bit of variation in terms of promotion of faculty from different institutions, and I just wonder if there's sort of like a uniform kind of standard, or there's like a wide distribution of like using publications, education effort. I mean, that's pretty much, it's a lot more complicated question, but yeah, just wondering how faculty get promoted over the country, what criteria is being used, and and all that stuff. How things factor into promotions.
Different for each institution.
Yeah. Right.
Just another question about the research. So if you open a brand new freestanding ED 2 years ago and you hire 5 docs to staff that essentially, and they're all part of your faculty, that definitely dilutes out your research time if that group is totally clinical, right? I mean, the way your math is. The opposite would be is if you hire 2 new research faculty who are 80% research, that would increase that number. Is that the way I'm understanding this? Because what your 6% number overall doesn't really tell me, I guess, like are most of the faculty all engaged? I mean, 25, 30 years ago, in our shop and a lot of shops, everybody was, expected to do this much research. So the percentage was probably more evenly spread than it is today. That's my gestalt of all this. But any thoughts about that?
Yeah, the faculty are actually listed and are related to a facility. And so if you hire faculty and they work in a freestanding environment, they can be separated from those that are related to an academic environment. The data that we're presenting here, I believe, are those faculty that are tied to an academic environment, right? So if you have a freestanding or a community ED that's staffed by your faculty, I believe those, we'll have to check the numbers, but I believe those faculty are excluded from the research question. But I'll check that to be sure that.
The other big question I had was like advanced degree faculty that are in your department, the impact that had on research. Did you look at that in any way? In other words, PhDs, masters?
We did not look at it in terms of research. We looked at it in terms of salary, and we know there's no difference in terms of salary whether you have multiple advanced degrees, but not in terms of research, and that's a question we can ask.
Yeah, and I don't mean that necessarily, but I do mean if you hire PhDs to help with a lot of your publications that aren't even MDs.
So we did ask about the research. We do ask questions about research support, and PhDs would be considered in that, and so we do have some questions about the research infrastructure in your department, and there is that data available. Yeah.
Just a comment. 25 or 30 years ago, when all faculty were expected to do research, there was very little research funding. And what funding was there often came from industry. And so I think one of the ways in that we are looking at individual departments is based on their total research dollars, which gives a fairly good assessment of what the amount of research that's going on in a particular place, irrespective of the total number of faculty.
Yes.
The question is, I just wanted if I wanted to drill down on this data more, is it publicly available? I was thinking specifically about looking at stipends for assistant program director versus program director at different academic ranks, assistant, associate, full professor. I'm just wondering if there's a way I can look at that without wasting your time.
I didn't hear.
It's publicly available data.
This data is available to the members of AAAEM and AACEM.
Okay. Do you know if that sort of data exists in that?
Yeah.
It does. Okay. Thanks.
And some of it's slowly being published. So some of that stuff is coming out. We're just starting with publications from this database now, and so you'll be seeing publications in AEM, in Academic Emergency Medicine.
Yeah, great. I just saw the overall faculty by academic rank, and I saw the data by position, but I didn't see the position by academic rank.
It's there.
There's a lot of information.
There's a lot of it.
I love information. Spreadsheet addict, 12-step program.
Yeah. Join the group. Come join us. Well, if there's no other questions, thank you very much for your time. Have a great rest of the conference. Thank you.